This is the second in a four-part webinar series that's focused on implicit bias in mental health services. Our last webinar was on starting with the individual, and we will share the link to the recording if you missed that. My name is Rochelle Espiritu, and we're pleased that you're joining us today. Before we begin, we just need to share this disclaimer since our team is funded by SAMHSA, so you can read that. And here are your presenter team members for today. I serve as the co-director for the Pacific Southwest Mental Health Technology Transfer Center, and I'm also a founding partner with Change Matrix. Change Matrix is a partner on the Pacific Southwest Mental Health Technology Transfer Center with the Center for Applied Research Solutions, or CARS, who is the prime for this center. My background is in clinical psychology. I'm a first-generation Filipina, and I've focused most of my career on working with diverse and under-resourced populations in the areas of mental health, substance use, leadership, culturally responsive and equitable evaluation, and systems change. I will now turn it over to Caitlin.
Hello. MHTTC. I'm also a change specialist with Change Matrix. My background is in law and early childhood education. I recently joined the team in February, and I previously worked at the Michigan Department of Education, where I focused on early childhood systems coordination and collaboration.
Thanks. Suganya.
Good afternoon and good evening, everyone. My name is Suganya Sakalingam, and I'm a technology transfer specialist for the Pacific Southwest Mental Health Technology Transfer Center, and also a founding partner at Change Matrix. My background is in public health with a focus on maternal and child health. And however, for the last 20 years, I've also worked on behavioral health issues. My current focus areas are equity and leadership development with the intent of guiding systems transformation. So that's who we are. Thank you.
Thank you. So we are with the Pacific Southwest Mental Health TTC, and it is part of SAMHSA's new network that provides training and capacity building to our nation in a regional approach. And so the Pacific Southwest MHTTC serves the mental health workforce in Arizona, California, Hawaii, Nevada, and the Pacific Islands of American Samoa, Guam, Marshall Islands, the Federated States of Micronesia, the Northern Mariana Islands, and Palau. Our role is to provide training, TA, and resource dissemination that supports the mental health workforce. We have a focus on evidence-based practices, and given our regional focus, really try to also highlight culturally adapted practices as well. So we do this through a variety of services. They are all free, and so we want you to access these TA resources that we have. As you can imagine, we are doing a lot more in the virtual realm, and so many of our services are available to the nation, really, because of the virtual aspect of the way we're sharing some of our resources as well. Okay, so here's our agenda for today. We've done welcome and introductions. We're going to launch with just making sure we create some common ground around implicit bias and microaggressions. We want to do this recognizing that we know not everyone was on our first session, so we'll do that fairly quickly. We're then going to walk through exploring how implicit bias impacts our work with clients in mental health settings, and we'll do that through a bit of a journey map where we can see the different points of where clients intersect with the mental health setting. We also want to provide some space to talk a bit about the impact of COVID-19, and I will say even kind of broader, the racial injustices that are occurring on the client-provider relationship. And throughout the entire session, we will be talking about strategies for combating implicit bias at different points in the journey that a client has. We also invite you to share your Q&A and your feedback at any point during the session. I will be monitoring the Q&A and the comments, throughout the time, so feel free to use that as a way to communicate with us as well. So I think many of you have already done this, but if you have not yet, please go ahead and do share your oh no, you've been sharing your introductions, but we would like to know one thing that you are hoping to learn from this session. So we're going to ask you to share that, so that helps us kind of get a sense of what your interests are. So if you can, please use the comment box to share one thing that you are hoping to learn from this session. And we'll just highlight a couple things that come through. So it looks like there's an interest in how to better serve your clients. Thank you. How to connect with certain populations, it sounds like, is also of interest. How to address bias in the workforce. I like this, keeping up with personal and professional accountability in our work. Oh, how to survive 2020 and beyond turmoil. Yes, right? We all need that. I like this. This is with kind of the focus on self, like recognizing what our own internal biases are, how we increase awareness about how it shows up both within ourselves as well as in our interactions with our clients. Great. What somebody as a white ally can do to address and understand implicit bias as a therapist. Great. Thank you so much. Please go ahead and keep them coming in. I do want to note that Joanne does save these chats so that we can also share some of these out with the group, because I know oftentimes there's a lot of very rich and valuable information in what you all share as a community too. So I'll go ahead and pass it over to Caitlin.
Great. So what we're going to first do is create some common ground around our understanding of implicit bias. So in a moment, we're going to ask you to share one word that comes to mind when you hear the term implicit bias. And instead of doing this in the chat box, we're using something called Poll Everywhere to collect your thoughts. In a minute, a screen is going to be pulled up, but essentially the words that you put into this poll are going to form a word cloud. So we're asking you to please keep it to one word if possible. That makes the word cloud work a little better. And the way you can participate is by going to www.pollev.com/changematrix335, or you can text changematrix335 to 22333 to join. And Joanne put the link to Poll Everywhere as well as the text instructions in the comment box. You can just copy and paste and put that right in your browser, or if you'd rather, you can use your phone and text. So as Rochelle is pulling up our Poll Everywhere, just think in your mind about one word that comes to mind when you hear the term implicit bias.
Right.
And it looks like we're getting some responses, which is great.
So
and the way the word cloud works,
screen, right?
Yes.
I see. Yep, you see it. Looks great. The way it works, that the more people who use a certain word, the word gets bigger. So we see judgment and unconscious as really large words in this word cloud, which means that a lot of people are using that word. That's something that comes to their mind when they hear the word implicit bias. We see the word stereotype or automatic, prejudice, learned. There's also some participants who are participating via the chat box, writing words like unequal, change, assumption, exclusion, unintentional. Stereotypes, systemic. Great. still seem like a lot of responses are coming in, Rochelle.
Yeah, but I think we can move on. I'll leave it open
Okay.
so we can also share this as a screenshot with participants afterwards.
Great. So as Rochelle said, we'll share this data with you, but just to provide a little bit more information on implicit bias. As Rochelle mentioned earlier, this is part of a 4-part series. And in our first series, we focused on implicit bias and the role of the individual in mitigating bias in mental health settings. So if you're interested in a deeper dive on the fundamentals of implicit bias, please consider viewing the recording of our first webinar in our series. And that focuses on the role of the individual, as I said. But as a brief overview, implicit or subconscious bias refers to the attitudes or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. Implicit biases are robust. Our brain actually needs them to help us function. Implicit and explicit are related concepts, but they're really distinct mental constructs. One of the differences is that implicit associations or implicit biases do not necessarily align with what we say our beliefs are. And we generally hold implicit biases, that's not always true, but generally within that favor our own in-group, so people who are like us. Implicit biases have real-world effects on our behavior and the way that we interact with other people, including our clients, if we work with clients or patients. Implicit biases are malleable, therefore they can be unlearned, which I think is good news for some of us. We cannot underscore enough that implicit bias is unconscious and it's involuntary, and we all have biases. They can be both positive or they can be negative. This is just how our brain operates. So now as we move on to the next slide, if you look at this slide, there is a link to a YouTube video. We're not going to play the video right now because there is a little bit of difficulty in moving between video and the Adobe Connect platform. But perhaps you've seen this video in your own work or in your own learning around implicit bias or before viewing this webinar. It's called Peanut Butter, Jelly, and Racism. Over the past few years, the term and concept of implicit bias has really permeated society. Issues in criminal justice and legal fields, such as wrongful convictions and interactions between Black Americans and the police, were pivotal for bringing implicit bias into major news headlines. So this video is a video from the New York Times that we think does a good job of explaining implicit bias in a succinct way. And even though we're not viewing it right now, I'm going to describe it a little bit to you, and you can also watch it on your own. It's only about 2.5 minutes long, so it's brief. The video describes implicit biases as basically thought processes that happen without you even knowing it. There are little mental shortcuts that hold judgments you might not agree with, and sometimes those shortcuts are based on race or other factors. One of the key points is that implicit bias is different from racism. When we ask people what comes to mind when they think of implicit bias, racism inevitably comes up. But racism is explicit, while implicit bias comes from your normal mental functioning. The PB&J reference comes in with respect to association. So for example, if I say peanut butter, then perhaps you'll think jelly right away. That's an association because throughout your life, perhaps as a child, you learned that peanut butter and jelly go together. Similarly, messages from the media overrepresent the pairing of Black men and violent crime. And because of that, people are essentially taught that Black men are violent and aggressive. They then begin to associate Black men with violence. So again, this is sort of along the same lines as association with peanut butter and jelly. This is not an excuse for biases, but an explanation of how and why it happens, and a place to really begin to break down these associations because awareness is really critical. One of the other things the video does that I think is really important, especially in work with clients, including in the mental health sector, is that it warns us about something called blind spot bias, and that allows us to see biases in others but not in ourselves. So if you ever hear someone say, I don't have biases, that's probably, well, pretty much not true. And so as providers and those working with the public around mental health or education or human services, It's really important to look inward and recognize our own biases. So here's a couple examples. So just in the chat, you can type yes or no. Are these examples of implicit bias? Latinos receive less pain medication than similarly situated white patients. Black patients receive psychiatric treatment half as often as white patients with the same disorder. People perceive those with a mental illness as more dangerous than those without a diagnosed mental illness. Oh, did you make a poll for this one, Joanne? Apologies.
No, a lot of people are writing yes in the comment box.
Yes. So yes, these are actually all examples of implicit bias. And so I'm wondering if from your perspective or experience, can you share or think of examples of implicit bias in the mental health system? And the way we're collecting information around this is there is a poll that should have popped up for you, and you can type your answer in the box. It says type your answer here, and your answer will be displayed in the answer box. So it looks like people are participating in the poll, which is great. A few answers, and you should be able to see them on your screen, include women being seen as overdramatic, people with certain disorders such as schizophrenia are seen as dangerous, low-income clients have drug issues, private insurance patients are viewed as getting better than public insurance, those with public insurance. There seems to be biases around the perception of how children of color are being diagnosed more with oppositional type disorders. Lots of comments around how those from lower economic status or from minorities are viewed with respect to treatment. And that substance use and mental health go one in one. So we're seeing a lot of, one of the things I think that the responses show, which is also important to highlight, is that certainly there's been a lot of attention to implicit bias with respect to race or culture, but implicit bias can also happen with respect to age or gender or sexual orientation and other characteristics. So I think we are ready to move on. So now we're going to talk briefly about microaggressions. Imagine these scenarios. So after a presentation, a white employee tells their Latinx colleague that they are so articulate. A classmate remarks to their peer that they do not look like a lesbian. While working on a grant proposal, someone asks their Asian colleague who does not work in a business or numbers role to help them with the budget because Asians are so good at math. There's a name for what's happening in these situations when a bias shows up in our behavior and that leaves people feeling uncomfortable or awkward or insulted, and that term is called microaggressions. Microaggressions are remarks, questions, or actions that are painful because they have to do with someone's membership in a group that is discriminated against or stereotyped in some way. And the key to why this is so disconcerting for people or uncomfortable is because microaggressions happen every day. They're really casual. It's often not intended to do any harm. It happens frequently. And sometimes microaggressions might seem like a compliment, like the example of the employee asking their Asian colleague for help on a math issue. However, this is still a manifestation of a bias and ignores someone's individual attributes. It also perpetuates stereotypes and ascribes intelligence and excludes those who do not fit those stereotypes. It also ignores there's diversity amongst people in the same group. So psychologist Daryl W. Sue defined the term microaggressions as the everyday slights, indignities, put-downs, and insults that people of color, women, LGBT populations, or those who are marginalized experience in their day-to-day interactions with people. And we're going to talk a bit more about microaggressions as we go on throughout the presentation. But again, there's something that happens every day and something to be aware of because it's how we manifest our bias. So now I'm going to turn over to Siganya.
Thank you. So we just spoke about microaggressions, and we've sort of looked at implicit bias. So let's look at it in terms of client interactions. Our biases impact our perceptions of people, including our clients, which may then influence how we communicate with them or our decision making, including how we approach client treatment and follow-up. Research studies indicate that among mental health and health professionals, there is implicit biases towards people of color, the elderly, obese patients, and even those with mental illness, among other groups. Unchecked bias can have real impacts on client outcomes. In one study, American clinicians looked at a hypothetical white patient in comparison with an identical black patient. And what they considered and assumed was that the white patient might significantly improve, adhere to treatment, and be more personally responsible for his health. Similarly, microaggressions occur in the mental health care setting, and it can impact the way providers behave towards clients and their families. Likewise, clients too have biases towards providers and display this through the way they access services, the way they utilize services, and ultimately we see it in the outcomes that they indicate or show. Therefore, it's really important to check our biases and how they manifest in all our interactions with clients so that we can build relationships that achieve maximum outcomes for those we serve. So let's look at it from what that journey, a client journey, would look like. Bias can manifest at any stage of a client's journey through the mental health system or in an individual provider's office. This map shows the different steps from making an appointment to receiving an invoice, up to receiving an invoice. So you can see that whole journey. We know this may look different in different settings. So in your settings, this journey might not work out exactly the way we've portrayed it, but we'll use this as an example to show what happens. We want to be able to show through this graphic where bias manifests in the intake, in the interactions with providers, and in the follow-up. For each phase, we're going to offer some examples of potential bias and microaggressions, and we're going to share some strategies for combating bias in your work with clients, and want you to also be thinking about other potential strategies that you've seen or you've actually practiced. So let's consider the intake. And in the intake, the client schedules an appointment with the receptionist or might even do it online. And then the client arrives for the appointment, checks in with reception, and proceeds to the waiting area. So this is the intake process. We want to be able to look at what then happens when a client does come to the healthcare setting. So here is so we're going to meet May. May has arrived in Arizona from Burma 2 years ago. She struggles significantly with past traumas she's experienced in Burma. May's refugee caseworker recommended that she seek mental health counseling because of her severe symptoms of trauma. May only speaks Burmese, and her internet access is unreliable, and besides that, she doesn't drive because she doesn't have a license. So May calls the local therapist's office. Nobody there speaks Burmese, and she cannot communicate. So what she does is she asks her friend for help, and her friend a few days later makes the appointment on the office's online patient portal. May indicates in the portal through the help from her friend that she only speaks Burmese. However, what happens is all her reminders come to her in English. When she arrives for the appointment, she's 15 minutes late because she uses the bus as a transportation, and we know what bus schedules are like. Her friend comes with her to translate and tells May that the receptionist is irritated that they are late. May is surprised that there are no Burmese reading materials in the waiting room because of the growth of Burmese residents in the area over the last several years. And this might be the case when you live in an area or a town where they serve as a refugee or an asylee resettlement center. In those instances, large population groups of a certain subpopulation may be brought into that resettlement area. So as May waits, a staff person comes to her and begins to show her a form she does not recognize. She then apologizes and moves to another patient in the waiting area. May's friend explains that the staff person mistook her for another Asian patient. And in this case, what happens is there is mistaken identity and mistaken relationship. I'm going to explore this a little bit with you, but before that, I'm going to go back to this slide. Because what has happened here, what we do see is that the client bias and consequences, because of the lack of cultural competence training or training around implicit bias, can lead to many different ways in which the client may experience the encounter. What happens is there is an assumption that when clients do not speak English or they cannot easily access the internet or they have transportation, then if they have it, the assumption is that they have these things. So the assumption is towards dominant cultures and socioeconomic statuses that are higher that would allow for English speaking and easy access to internet and transportation. This has an impact on access to mental health care and services in many real ways, as we will see throughout this encounter that May has. When we think about this in terms of other population groups, what we do know is that Black Americans receive psychiatric treatment at half the rate of whites. And according to the U.S. Health and Human Services data, Latinx or Hispanic Americans, depending on how you identify them, are also half as likely as non-Hispanic whites to receive mental health treatment. So as you can see, the gaps in access to services are so tied to how we think people access services and therefore how we make those services available to them. Implicit bias can manifest as in microaggressions as well in the case of May, and she experiences these microaggressions because they have really not tried to communicate with her in her own language when they leave reminders. They don't have someone in the intake area who can support her. Knowing that she's coming in and that she's Burmese, there's still no interpreter or translator. And all of this is a sort of a message, a message to May that she should really assimilate and be an English speaker to access care. This really adds to the feeling of second-class citizenship or otherness that people who come in as immigrants and refugees and asylees can feel in a dominant culture that really is mostly white and middle class. And so microaggressions can manifest in the kind of scenario that May comes into. First of all, there are no materials whatsoever in Burmese. And even if there isn't materials, even having some pictures or graphics that shows a variety of diverse cultural groups might be helpful. And given that this is a resettlement center, there might even be some artifacts and works of art that could be brought into the the reception room that can make people feel welcomed. However, what we do is that what this particular center is indicating is that they have not paid attention to or given consideration to the culture of the clients who come to be served by them, and there isn't the capacity to communicate with May effectively. So we will be talking a little bit about facilities and what organizations can do in our next webinar, which is really looking at organizational culture and climate. So it's implicit bias from the perspective of organizational culture and climate. But for now, it's just a recognition that in small ways, May could have been made to feel welcome, but they were just not there. They were completely missing. And on top of that, she is also mistaken for someone else, because what happens is that the intake person comes by and the staff person mistakes her for another Asian patient, because you know what? All Asians look alike sometimes. And so there is mistaken identity. The other thing that often happens is there is an assumption that is made about family makeup and partners. We are a pretty, our families are small, they're very independent. There is, sort of nuclear family systems that exist in the US, and yet a lot of cultures who have immigrated into this country came from very large extended family systems. And so there may be people, not only will the significant other or the spouse come to the clinic or the setting, but you might even have parents, grandparents coming along. And so we need to think about these differences in identity and relationships that exist amongst different population groups.
We wanted to acknowledge,
So, Rochelle?
especially in this, sorry, can you hear me, Suganya?
Yeah, now we can hear you.
Yeah, so we wanted to acknowledge that the way services look in the time of a pandemic is different now. Understanding that many service organizations have had to limit in-person contact. For some states, you are now starting to reopen, and there are probably different processes and strategies that your organizations are having to take. So we wanted to leave some space to find out from you all, especially as you're thinking about this intake process. How has COVID impacted your intake and initial interactions? We're assuming that many of the organizations are doing work over the telephone, or you're utilizing telehealth as a way to connect with your clients. And just wanted to take a moment to think about what are some of the ways implicit bias might show up in those interactions. So we'll give you a moment to share first a little bit about how the pandemic is impacting the intake, and then would love to hear from you also about, as you've heard about this this case study of May and what it was like for her when she came in person, what are some of those points of what might be happening in terms of implicit bias when you're thinking about a different connections, by virtual connections. So yeah, I'm seeing some points that, you know, part of our assumptions might be that everyone has technology. And so that is something that I think we need to check. We might also have an assumption that it's okay for everyone to be on video. And so the privacy concerns are something for us, I think, to constantly check, that we might be making assumptions about what the environment looks like, or that clients have a private space when they don't, maybe. I think the other thing to note that I'm seeing in the chat is also just the real, how to read some of the social cues that would be different on a video screen or on phone versus in person. So I think just seeing a lot of different examples here, assumptions about socioeconomic status as well. Even noticing a decrease in clients' ability to follow through, and kind of what are some of the biases that we might have around that, assumptions we might make about interest in treatment or not, just kind of based on maybe how they follow up or not, what might be some of the other reasons for non-compliance. So anyway, thank you for sharing some of those examples. Those are really helpful, I think, for everyone to see. We will go on to the next slide. So we wanted... Sorry. Thank you. So we wanted to share some individual actions that are important to consider. I think that was something that was raised at the beginning around what is my responsibility in this? What can I do? So this is a nice framework to think about in its action, and we'll go through each of the different segments in here. But essentially what we want to highlight is that ignoring comments that you might hear or behaviors that you might see, either in yourself or in others, can be tempting, especially if you feel uncomfortable about it. But then that also sends a message that such comments or behaviors are okay. So we want you to challenge yourself to decide if pursuing a topic or a statement or behavior is in the best interest of the situation for the individual or in a group, depending on the context. So we encourage you to legitimize discussion around this. So try not to avoid changing the subject or dismissing topics of race, gender, sexuality, citizenship status, disability, as they arise, because dismissing it is also a type of microaggression against people. So this method includes ways to address microaggressions. So A is for asking clarifying questions. This really helps to understand the intentions, and coming from a place of curiosity and not judgment will certainly help the situation. So as you ask those clarifying questions, then carefully listen. Like, sometimes we ask questions, but we already feel like we know what the answer should be, but we're encouraging you to carefully listen, to actively listen to their responses. If they disagree with your paraphrase or have a different meaning, then maybe you don't pursue the conversation. But if you don't listen, then you don't understand the intent behind the statement. Tell others what you observed. So you might say, I noticed that you said this, or I noticed that you did this. Why? You know, and again, it comes from a place of curiosity. So consider, then the I is consider the impact for yourself or others. So you might think about asking questions like, what do you think people think when they hear that type of comment? Or what do you think a client might feel or experience if you did this? Or what kind of message do you think this behavior might send to a client? So really thinking about how what the impact of implicit bias or a microaggression is on the other person. O is for owning your own response. We all, as Caitlin said earlier, we all have biases. Every single one of us has a bias. But the good thing is that that they are malleable. And so part of what we need to do is kind of own what our own thoughts and feelings are around the impact of a microaggression. So in conversation with somebody, one might say, when I hear your comment, this is how I think or how I feel. So I often get the question of, like, where are you from? I shared earlier that I'm Asian and I was born in the Philippines, but that is also a type of microaggression against Asians that we're often asked where we're from, which kind of gives the message of you can't be from the United States, that you're a foreigner. And so one thing that I've started doing is when I hear you ask me a question about where I am from, it makes me feel like I can't belong here, or that you're assuming that I'm not American. So kind of sharing what the feeling is around that is helpful. And then next steps is really trying to think about what are some of the appropriate actions that can be taken. So one might say, I'd appreciate it if you can consider using a different term because it's inconsistent with our agreement, or it might be more helpful if you ask me what my ethnic background was or what my country of origin is. So providing a different way of being. So this is a framework that you can use at every stage of your interaction with clients to really help you check your own biases, how they manifest, and how you can combat the bias of others and make some positive change. Okay, I think I'm sending this back to you, Saganya, right? Oh no, I'm going on. Sorry. Sorry, I got confused here. So here are some additional strategies. Let's see here, where am I? Okay, so you can show clients that they are welcome and that you are aware of the different cultures that are present in your community. You can also, as an organization, demonstrate community partnerships, which can really, which can include things like working with local community or resettlement organizations, both for interpretation and training. Sometimes these kinds of trainings are only offered to providers, but we really stress the fact that everyone in the organization benefits from this kind of training. So that includes frontline staff, you know, whoever's the first person that somebody meets when they walk into the door is really important, because that person is responsible for creating that welcoming environment that is the beginning of a successful provider-client relationship. Some of these kind of trainings can also help to build listening skills and empathy and teach staff to communicate in a way that is not re-traumatizing and does not make assumptions based on dominant culture. So these are really important skills for those, for the staff who meet a client first before an actual provider treatment session. Another strategy that we've also seen in other organizations is providing the opportunity for walk-in appointments, because that often helps for those clients who have barriers to transportation or technology, but it also helps patients who have inconsistent schedules or maybe who are less familiar with U.S. dominant culture norms around making appointments and interacting with the mental health care system, and have kind of different values around time. And so that can be another strategy that can help. So we'd love to hear from you. What are some of the strategies that you're seeing in your own organization that help to mitigate implicit bias in the intake processes? So we'd love to hear from you around what are some things that have been helpful for you. So we see that translation services are helpful. There are those translation cards that are available that many organizations use. So it doesn't assume that you can speak in English. So what language is your language of your heart, and they have things already translated. So seeing a lot of those comments in the poll. Love the ask, don't assume, and so that's kind of that taking action method where we ask with curiosity and not make any assumptions. It looks like that in one organization, they know they have a large Hispanic population in the area, and so already have everything offered in both Spanish and English. So great. Building rapport with the client, meeting the client in his or her or their place. Kind of thinking about when services are provided differently. So I see some weekend appointments being offered, home and community-based services, providing childcare. There's a Know Me initiative, so it's asking for preferred name, pronouns, and language, which I know we've been seeing a lot more, even on these kind of virtual platforms. More and more, I think people are inviting people to share their preferred pronouns when they're introducing themselves, so we're not making assumptions about gender or sexual identity. Great. Thank you. So I think we'll go ahead and move on to the next set of slides around the provider-client meeting.
Great, and this is Caitlin again. As Rochelle said, we're now going to move on to the client-provider meeting. And just a couple notes, we know that this journey may look different for you. You may work in a school setting or another type of setting. We also acknowledge that this may look really different, as we discussed during the COVID-19 pandemic. So when we're talking about client-provider meetings for this particular journey, we're talking about when the client meets with their provider, when their provider makes their initial treatment decision. So we're going to do another poll, and we'd love for you to share from your own experience, what are some assumptions that clinicians might make about clients? And again, you can type your answer into the box under the question, or if you're having some difficulty navigating that, please feel free to type in the comments box. We're seeing that there are assumptions around people's sexuality, around their intelligence, around whether they understand the process, or there's assumptions that people will automatically understand the treatment process, sexual orientation, around drug use or drug-seeking behavior, education level, service experience, assumptions around based on how they look, that their children don't look alike, and so there's questions about family makeup. That's something that Zaganya touched on earlier around mistaken relationship, and ability to engage in treatment. So it sounds like there are a lot of assumptions that clinicians can make about clients, and I think that we can move on to the next slide. Some of the assumptions that we've mentioned here around behavior of certain cultural groups and other sorts of stereotypes, these are biases that we carry in our personal lives, and they can carry into our client relationships. So we're going to go back to talking about May, our fictional client, and if we could move on to the next part of the animation. So May moves on to her appointment with the therapist, who is a white male. The practice has a Burmese interpreter available via phone for her appointment. May feels uncomfortable communicating about her mental health through an interpreter. She also isn't sure they are accurately communicating what she or the therapist is saying. So one of the ways that bias can manifest in client interactions is through a lack of attention to client race or client culture, and how race and culture, different races and cultures perceive mental health services or experiences with trauma, and the way that people express themselves or interact with others generally. So One of the things that's sometimes problematic is a lack of attention to intersectionality. So when participants identify microaggressions or feelings of awkward encounters in healthcare, they could not attribute to just race. So people are not just one thing. So looking at the intersection of race, gender, disability, language, insurance status, that's something that all of you mentioned, not all of you, but some of you mentioned as being an assumption that people make based on people's public or private insurance status. So May in this vignette is uncomfortable with the use of an interpreter. Is the provider asking her if she understands the process, explaining how working with an interpreter actually works, acknowledging cultural attitudes around how she views an interpreter, acknowledging biases of interpreters, because again, an interpreter is also a person, and every person has biases, so are they included in training? Is that something that we're all checking for understanding? There's also a concept in this work called an entitled examiner, and this is when providers ask probing questions outside what feels necessary for medical care. So someone mentioned earlier about multiracial clients and people asking about family composition, or if the mother or father was the real parent. That's something that can happen, with an entitled examiner. But also, kind of reverse can happen, and that's when providers ignore race and culture, or their potential impact on health or mental health is just not communicated. So imagine if as treatment continues, and a therapist never thinks about or asks about how her Burmese culture or experience as a refugee impacts her. Would this impact how she feels about having, being in therapy, how she interacts with her therapist, does her past experience make her feel comfortable about having a male provider? These are all things that eventually would need to be explored. So now as we move forward, this chart provides a visual representation of how implicit bias manifests in client-facing services, including mental or behavioral health. As you mentioned before, our biases impact our perceptions of people, including our clients. And then this influences how we communicate with them, our decision-making, including how we approach client treatment. This graphic shows the processes behind provider-patient interactions and how these ultimately impact treatment outcomes. So interactions with clients may activate provider bias. It can distort our judgment. Bias impacts my lived experience and vice versa. So, I may have a bias against someone who's against the elderly. I think they're forgetful. I think they won't adhere to their treatment. So I don't intensify their medication or their treatment regularity even though they need it. And so you see this in mental health and education, on honors placement decisions, and in other sectors. But on the other hand, patients are also people who bring their biases to meetings with providers. And there's a number of studies, surveys that indicate that clients have biases and that sometimes they ask for reassignment based on provider age, race, sexual orientation, and gender. And so this is also something to be aware of in your work with your staff if you have them, and how you can support staff who are the subject of biases or microaggression. We are going to talk a little bit more about organizational strategies for this in our July session on organizational culture and the intersection of implicit bias. But as we move on, you'll see that client bias, or the feeling that the provider is biased towards them, can impact treatment. Interaction between provider and client perceptions of one another. Everything going on internally is affecting how we interact with one another. So maybe I'm a parent of lower socioeconomic class and my work schedule is variable, and I know conversations with other parents that the school counselor is not asking me to volunteer or trying as hard to have me come to parent conferences as they are with wealthier parents. How does this impact my engagement and trust? And is the provider not having high expectations or the same expectations of certain clients based on certain characteristics? So as a provider, I may allow this to impact my treatment decisions based on these expectations. And as a client, the way I feel about my provider and their expectations and how much I trust them may impact my investment in treatment or services. And all of this impacts outcomes, which is ultimately what we want, are positive outcomes for our clients. So as we move forward, in your experience, where else have you seen implicit bias in client interaction? Or how else? And again, this is another poll. And we had a comment in the comment box that Jessica always makes sure she offers choices about comfort level and characteristics, trying to see if her clients feel comfortable in their experience and who they're working with. Someone mentions that they feel that their clients have some bias because they're an older white woman. So as you mentioned, clients have biases also. People are mentioning in other sectors that they see implicit bias in education, housing, transportation, with respect to medications management. In their workplace, in certain mandated services. So we're seeing that there's bias both within our workplaces and also within other sectors as well. So I think we can move on to the next slide. So here we're going to share some strategies for mitigating implicit bias in provider-client interactions. So strategies for mitigating bias in provider-client interactions require both individual work and organizational policy and work. So if you're interested in the role of organizations in mitigating bias, join us for our next webinar on July 22nd. But many of these strategies center on educating yourself through partnerships and through education. Reaching out to the community helps make sure you receive critical information about a culture directly from its members, which reduces the likelihood of inadvertent re-traumatization. Helps you create an environment that reflects your community's values. So again, maybe in a culture where families make decisions about healthcare, you have a waiting area that includes space for family. This reduces the likelihood of pathologizing cultural values around communication, and it's helpful in understanding context. And it's a critical step towards moving beyond color blindness or bias blindness, which we talked about before. Because again, not all bias is race-based. So training and performance reviews are another way that you can, another strategy for mitigating implicit bias in provider-client interactions. If you require, if you have community members work with you to co-design trainings that may help you avoid pitfalls in treatment. So the Burmese example for May, perhaps the practice or the provider could reach out to Burmese community organizations for some assistance in designing culturally appropriate training and help you understand the challenges, the strengths of your community, and problem solve. This also demonstrates a commitment to cultural responsiveness and equity, which is really important. And we'll talk more about the importance of diversity in workforce and workforce representation in the organizational section. So if we move forward, so what are other strategies that you use to mitigate bias in client-provider interactions? So we mentioned some that were training, again, perhaps requiring cultural competence and performance reviews as a measure, which again might help elevate it as a value for your organization and something that all staff have to honor. We talked about community partnerships. I see, again, staff education and training. Client feedback surveys, that's a great strategy to learn how you're doing and to check in. That can help with accountability. Checking in for understanding. So if you don't understand something, asking questions. doing quality callbacks. So supervisors call clients throughout the process to see if there are any issues. So I like this, introducing yourself with pronouns to promote a safe space, to sort of have that, create that initial comfort level. Open discussions even when they're hard. So again, not ignoring race or culture. And give people just another minute or two to respond. And again, if you're having trouble with the poll, please feel free to type in the comment box. Education on historical and cultural understanding, so understanding historical context. Great. So thank you so much for sharing your responses with all of us. I think that we are able to move on to the next section in our client journey, which will focus on follow-up. I'm going to turn this over to Siganya.
Thank you, Caitlin. So we've looked at the intake process, then we've looked at the client-provider interaction, and now, you know, the visit to the provider is done, and so what follows is there might be sort of a request to come back for more visits. There might be a referral to another provider. There might be prescriptions that are provided, and then the client then sort of works with the provider and the clinic or the healthcare setting to either set up future sessions with the provider or actually do the referral. And the other part of this is, after all of this is done, the client then receives the billing invoice, and at some point the provider might follow up with the client. So these are some of the ways in which follow-up occur, but every organization is different, every healthcare setting is different, and what might constitute as follow-up would be something for you to think about and to consider, and then to think about where bias might set in. What we're going to do here is talk a little bit in what happens when the client has completed and is in the process of follow-up. So, first, May's therapist tells her that she needs to make another appointment. He says he doesn't know if she has ever been to a U.S. medical appointment before, but coming on time and following the plan is important. Then, what May feels is very different feelings about it, but one of the feelings that is uppermost in her is that she thinks that he doesn't trust her, that even though he's then asked her to come back in 2 weeks' time, she's not sure if she wants to come back. And what happens is she doesn't make an appointment. Was I muted? No. Okay. And so she doesn't make an appointment to come back for the follow-up. So one of the things that we need to think about here in all of this that's happening is that providers sometimes might hold lower expectations about an individual because of many factors. It could be their race, their gender, their age, whether they have a high or a low socioeconomic status, whether they have educational level, and oftentimes if they are an immigrant or someone who has a different accent that clearly indicates that they are new to the country. all of these factors might arouse in the provider assumptions that this person isn't capable to follow through the request that the provider makes, and therefore that it would be very difficult for the client to adhere to the medication or even adhere to any of the treatment regimes and to actually then come back for a follow-up. So this provider, recognizing that May is totally new to the country, has decided that she won't be able to adhere to the appointments and may not follow through with any of the treatment. Now, we know that this is also the case with other population groups. What we do know is that providers rate white patients as more medically cooperative than most other population groups, and in particular, Black patients. We also see this not only in the health sector, we see these kinds of biases in other sectors as well, in education, in juvenile justice, in child welfare. So what we know is this is a pervasive feeling that providers might have, that due to lack of education, the assumptions are lack of education, low socioeconomic status, therefore unable to communicate effectively and follow through. What happens is that then, from the perspective of the client, this really leads to very negative feelings about the encounter, very negative feelings about the healthcare center that they are going to, and very negative feelings with providers. Not only the clinician, but it could even begin with the intake of staff in the front who might have been rude, or who might have been curt, or who never looked up to say hello. And so there are all these areas in which the client meets with different people in the healthcare setting, and if her interactions are all somewhat negative, there is no reason for her to feel that she can trust the setting, that she can trust the providers. And when there isn't any trust, then the chances of improvement, or the chances of following through with the treatment and the medical regimen is very low, and therefore very difficult to get the kinds of outcomes that we're looking for. So the major thing that we see is that really it's not just access that is impacted, but it is the intervention that is expected. And then in this instance, the follow-up is also impacted. They are not going to come back, and they are going to then not be able to improve their health as we would like them to. There's another area in which this also plays out, this bias, and that is in billing. All the billing is done in English. Oftentimes, the billing process is very complicated, and you might get the bill and it will be reams of items that you might have to pay for. And so one of the things that might happen is also the billing staff might make a lot of assumptions based on what they think is your socioeconomic status, and their first impressions of you might also mean that they think, oh, you're on, public insurance. And so those kinds of perceptions really impact what the follow-up billing process is. Likewise with prescriptions, getting the prescriptions, getting it in the pharmacy, using insurance, public insurance, all of these have implications to how the client feels in this health encounter. So as you think about this, think about what is now happening with COVID-19. Now, as we discussed earlier, that more likely than not, these are going to be virtual encounters, maybe a telehealth visit or a phone call. And sometimes I know in some instances it might be being able to actually use a virtual telephone process to communicate with the client. In that instance, think about the kinds of assumptions that might be made, and therefore the kinds of bias that might set in. And it is something that would be crucial for us to think about, because as we know, COVID-19 has disparately impacted communities, and therefore it is communities that are poor, communities that are Black and Hispanic that are being impacted by COVID-19. And so when you think about that and think about the potential for bias setting in through the televisits or through the phone, it becomes really critical. I know I saw someone writing saying that getting information about setting appointments through the mail becomes a very difficult process. Imagine also if you're in rural areas and the only thing that you can do is through these virtual visits, and right now they're inundated, and so it becomes a very difficult issue for clients to get their health visits in. And so one of the things that I would like to do at this point is think about how we can mitigate the implicit bias in this checkout process. So we want to include billing and reception staff in any training that we do. Oftentimes when we think about training, we provide training to the providers, maybe the frontline staff, nurses, social workers, clinicians, but we never think about billing and staff. We may not even think about the receptionists who may not have any, may not be doing any of the medical intake, but still is there to greet people and to get the appointments made. And so that's one thing that we really need to think about. The second thing is that recognizing and asking how we about follow-up appointments, whether clients will be available to make those appointments in this time of COVID-19. How do we do the follow-up appointments, and how do we even provide referrals? These are all considerations to make and questions and a conversation to have with your clients. Oftentimes, I think decisions get made, and appointments get made and referrals get made without often having a conversation with the client. And it becomes important at this point to ask the clients, what is it that they might be able to do, and how is it that they may be able to follow up on appointments and referrals? And one of the things that we have clearly seen through all of this is May is Burmese. She is a refugee. She's just come lately to the country. She has yet to learn English. And one of the things that would have been very, very helpful if in the intake process they had asked about language issues and that they had set up an interpreter for May, so that she could have had the communication with the provider that would have been most meaningful for her. And so one of the things we need to think about is that you don't often only think about interpreters at that point of the client-provider interaction, but you might also need to consider for the follow-up as well. Now, many communities have health navigators. They have cultural brokers. There are a lot of ethnic associations and communities that are willing to help and to volunteer and work with healthcare centers. And so I think that given that this was a resettlement area, if they had followed through and talked to someone in the resettlement area, that client-provider interaction could have been completely different experience for May. One of the other things to remember too is that when communication is a challenge, one of the things you want to do is once the first meeting is set up, to sort of set up the follow-up meetings quickly, so that one of the ways in which, if you have an interpreter, the interpreter can communicate with the client and can help to set up some of these follow-up activities. And that way, the interpreter is able to communicate with the client in the language that they understand best, and therefore they're able to determine calendar dates and all the complicated aspects of the follow-up process. Very often, what providers might do is they may meet with the client, they might do the diagnosis, they may provide the treatment, but they never check for understanding. And it is so critical if there is follow-up that is needed, and that if the treatment plan has to be adhered to, that the provider determines if the client has actually understood what has been stated. And so checking for understanding is a critical aspect of the follow-up process as well. So if we're thinking about now, and it may be for the immediate future, because we don't quite know when things will change, and when we might have vaccinations, and when social distancing will change, and all of those things that we currently do will change. Between now and that time, when we might go back to the way we provide services, we have to think about what is it that we can do in terms of follow-up and continued engagement of our clients with the health services that they need. It's particularly the case when we are thinking about mental health. And so during this time of COVID-19, when we know that there is so much stress and so much trauma, the follow-up becomes very critical, and ensuring that we have communicated effectively with our clients so that they will follow through is important for us to pay attention to. So one of the questions we have for you then is, what are other strategies that you might use to mitigate the challenges during follow-up?
Sagani, I'll just note that there were a couple of chat or comments around this. So, one person had shared that kind of asking questions of curiosity again, like, what's the best way to be in touch with you? How would you prefer to receive information? How do you prefer to be billed? So kind of asking those questions of curiosity.
And the same thing is coming up here as answers to, as for their preferred method of contact, ensure that you have multi-language materials, schedule the follow-up through the interpreter, offer to call the day before the appointment to confirm and remind, being open-minded, and of course training around cultural competency, health literacy, all of those are critical. And sort of ensuring, I think one of the main things is following up in a language that they understand in order that you can communicate effectively with them. So the last and final question I have for all of you is, please share one action you will take as a result of this workshop. This is really helpful for us to know what you've been able to take away from this time that you've spent with us, and what is it that you can immediately put to use. using the action method, being open-minded, ensuring organization has translation services. Quite a few people have talked about the action method. Learn a different language, someone wants to learn Spanish, share this information with your service staff, ask questions. Yes, inquiry is probably one of the strongest and most powerful tools that we can use. And then keep the notion that we all have biases and that it is at the forefront of our thought and thinking. These are great action items that all of you are hoping will be able to take back with you.
Yeah, Sagani, I'm just going back to the beginning of the comments box too to see what were things people were hoping to get out of this webinar.
Yes.
And you know, a lot was around how to increase our own awareness about biases that exist within ourselves and with our clients, how to catch them and mitigate them. So.
And you know, we shared this with when we were talking about implicit bias on an individual level. And if any of you missed it, someone asked, how do we know about our own biases? If you haven't had the opportunity to take the implicit association test, all you have to do is type IAT on your search engine, and you should get the Harvard IAT assessment. It's free, and you can test, you can check on a variety of different areas like age, gender, presidency, what else? Weight. So a lot of things on which we might have biases are taken into consideration in those tests. So thank you so much for sharing your thoughts on what it is that you will be taking with you, and we'll move to the next slide. And then I'll actually turn this over to Rochelle, because she's going to share some upcoming learning opportunities with all of you.
Yeah, great. Thank you, Saganya. So as I mentioned at the beginning, this is part of a 4-part series, and you know, I did see some comments in the comment and question box around kind of how implicit bias impacts our organizations and our systems, and so I encourage you to register for our July 22nd session, which is going to be looking at implicit bias in our organizational culture and climate. And then finally, the 4th session is on how implicit bias affects our work, looking at our engagement and outreach with communities. And if you missed the previous session, again, the recording is accessible through that link on the slide. We also want to share, as the Pacific Southwest MHTTC, we do have a whole series of different opportunities for you. We do want to highlight this one. It's around telehealth pearls, pitfalls, and strategies to improve the patient experience. We have a wonderful presenter for that who comes from a really different and interesting background, so I encourage you to register for that session as well. You can also see on our website all of our upcoming sessions as well as any archived ones too. And we do have all of our webinars recorded, so just wanted to provide this link for you as well. And finally, I think I mentioned this today, we are sending out a certificate of completion. We get that as a question oftentimes, so you will get one automatically, but if you are joining by phone only, please email Joanne at joshel@cars-rp.org. And finally, we're really excited that our center is now able to offer continuing education hours for all of you that need these. What will happen is at the end of the session, our feedback survey will pop up, and then after that you'll be directed to the appropriate link to take a 10-item post-survey, and then you will be, from there, if you get a score of 8 or better, you'll be moved on to a payment form. So we'll post that into, Joanne, I'm sorry, I don't have the link to the feedback survey, but if you could put that into there, that would be great. And finally, again, just thank you for being on the session today, as well as for all of your engagement. I think our sessions are richer because of the the feedback and the input that you provide. As trainers, we always know that oftentimes the gems and the knowledge sit with those with whom we're speaking. So thank you for sharing your experiences and your insights and your strategies with us. Please do complete the survey for us and feel free to reach out to us. As I said, our center does offer free professional development opportunities for the region that we serve. We're eager to hear about what's important for you and your community, so please do stay in touch with us. Thank you again to Caitlin and Saganya, who did most of the work around this training. Appreciate the content that you shared with our folks. And as soon as this screen closes, you will get a survey that will walk you through the processes I outlined, and you will also receive a follow-up email as well. Thank you, everyone. Enjoy the rest of your day.